Hi, it's Tim from ChiroUp, and today we're going to cover a basic hand and wrist evaluation. So we've taken our patient's history. The first thing that we're going to do is some inspection. We're looking for any obvious deformity. One of the things that we might see is a dislocation, oftentimes involving the distal interphalangeal joints. What's more common at those joints, though, would be a mallet finger or a baseball finger, where their distal finger extensor tendon has been ruptured because of forced flexion, and now it's stuck in that position. The other thing that we'll be looking for is the possibility of a ganglion cyst. A ganglion cyst is basically a synovial balloon coming out of one of the joints. It can really happen at any joint, especially in the hand, most commonly in the dorsal wrist or on the volar wrist. One of those two spots, we'll see a little bump. That's a fluid-filled cyst or a balloon. We'll also look for swelling, tenderness, and warmth in the area. That could indicate us to the possibility of some trauma, maybe a fracture. Fractures are most common in the distal phalanges, on the outside of the fifth metacarpal, or in one of the carpal bones, especially the anatomical snuff box. Remember, right on top of the thumb extensor tendons, right in there. When we have tenderness in that area, don't want to miss that one because that's a license stealer. We'll also inspect the patient's skin and say, are there any potential skin changes, any signs of dystrophy that could alert us to inflammatory arthropathy? Lesions like psoriasis certainly are a possibility, but also any skin or nail lesions indicate us to maybe some carpal tunnel syndrome. 1 in 5 carpal tunnel syndrome patients have some sign of skin or nail change, and it's not surprising that if the peripheral vasculature goes away, that the median nerve vasculature goes away as well. We'll palpate the joints for the possibility of osteoarthritis. That's going to be most common at the base of the thumb, and osteoarthritis at the distal and middle interphalangeal joints. Remember, inflammatory arthritis like rheumatoid typically is a bigger problem that affects the bigger joints. While we're palpating, we'll make sure that we touch the lunate. Sometimes we can get avascular necrosis of one of the carpal bones, most commonly the lunate, and that's known as Kienbach's disease. We'll also check for muscle wasting. What's the muscle bulk, especially the thenar eminence? Some atrophy in that area may mean a more significant case of carpal tunnel syndrome that's led to some atrophy. And while we're palpating, we'll check the radial and the ulnar pulses to see what's happening there and what's happening with capillary refill whenever that's possible. Now, range of motion wise, we're going to have the patient go through flexion of both wrists, through extension of both wrists. We're going to have them go in ulnar deviation, radial deviation, pronation, and supination. Then we can also do that in a resisted fashion where we have them do the same thing, extending upward and taking it back downward, and then ulnar deviation and radial deviation. So we're assessing not just the joint mobility, but also the muscle strength. Is there any sign of weakness in the area? Test the patient's strength by having them spread their fingers and squeeze our fingers together, and then we're going to have them spread their fingers apart and not let us squeeze their fingers together to see how those interossei are doing. We'll have the patient make a circle with their fingers, and we try to pull that apart, and they're not going to let us do that. The other thing that we'll do is check for a passive mobility, that when we get the muscle all the way down, relax for a second, and we take the joint with a little overpressure and passive flexion, passive extension, passive radial deviation, and ulnar deviation. Remember that the ligaments are the stabilizers at end range. So the muscles and tendons stabilize the joint throughout the range of motion. We'll test them throughout the range of motion. We'll test the ligaments at end range. We'll also test the sensitivity over the top of these extensor tendons for a possible irritation of de Quervain syndrome, which is oftentimes tender here and tender when we put the wrist into ulnar deviation. One of the things that we'll want to make sure that we're looking for is what's the mobility of each of the joints. So we're going to motion palpate each of the joints in the wrist to say, is there hyper or hypomobility? And then we'll motion palpate and joint stress test each of the digits. Imagine that each of these is a miniature knee. We're going to put some abduction and adduction stress force, some anterior and posterior shear through each one of those, particularly the ones that are tender. The motion palpation, we're going to follow up with an orthopedic assessment of the area. Now, our orthopedic assessment is going to be specific to whatever our differential diagnosis is, but some of the common tests that we'd use would be a Phelan's test of putting the wrist together, or a reverse Phelan's test where we've done both compression and now a stretch of the median nerve. We'll go back to recompress that median nerve with some manual carpal compression, and we can also do a Tinel's sign. Now, if it's not the median nerve that's involved, we have numbness and tingling in this area, and a median nerve problem that's coming from the carpal tunnel would typically affect the digits. But if the palm is involved, we know it has to be more than just the median nerve at the carpal tunnel. There's something happening upstream, because the palm is innervated by the palmar branch of the median nerve, which skips over the carpal tunnel to innervate the palm. So when we see numbness in the palm, now we're going to go upstream and check the pronator teres. We can do a pronator teres compression test, or we can have the pronator teres resisted test, which we're simply having that patient take their hand into resisted pronation against our forces. If there's an increase in hand paresthesia upon either of those maneuvers, we might be looking at an upchain problem. We'll also look if the patient has some numbness or tingling in the distribution of the radial nerve on the dorsum of their hand. Could it be a radial tunnel syndrome? Remember, the radial nerve emerges about 4 finger breadths distal to the lateral epicondyle. So again, compressing that area. Nerves don't like compression, they don't like stretch. And we can also do a resisted long finger extension test, having that patient push up against your resistance. And if that maneuver is more painful than passive flexion of the area, our diagnosis is probably radial tunnel syndrome versus lateral epicondylopathy. Those things look a whole lot alike. And finally, de Quervain's, we know we can do the test where the patient brings their thumb into their hand, squeezes their thumb, and then takes their hand down. That's pathognomonic for for de Quervain syndrome, stenosing tenosynovitis. One way that we can use for an extra differentiation is to have them go back into that same test again, take their thumb down, and now straighten their arm and laterally flex their head away. If that intensifies the pain, we know that there's some additional involvement of the radial nerve. It's not just the de Quervain syndrome that's causing the patient's symptoms. We can also do the hitchhiker sign, having the patient bring their thumb up like they're a hitchhiker against your resistance. An increase in discomfort in that area gives us a good alert that maybe there's some involvement here. On the opposite side of the wrist, we're looking for the TFCC, that a lot of times this little meniscus becomes irritated and it will become tender to the touch. Sometimes there's crepitus associated with it. And one good test is to grasp the patient's arm, apply axial compression and ulnar deviation. An irritated meniscus won't like that maneuver, and the patient's going to let you know. We can do our standard motor and reflex testing along the way, but one thing that we want, especially if there's paresthesia, numbness or weakness in the hand, is to make sure that we're assessing the nerves themselves. So we're going to do a stretch test of the median nerve by having the patient take their hand back, their wrist into extension, and laterally flex their head away. If there's an increase in paresthesia and numbness into the hand, the median nerve could be involved, either the carpal tunnel, the pronator teres, or upstream. The radial nerve tension test is very similar. We're going to tension the upper end of the radial nerve, again with contralateral lateral flexion, and the lower end by putting our hand back into a Butler tip position. And finally, the ulnar nerve stretch test for cubital tunnel syndrome is making a circle, having that patient bring that up to their face, and then flipping it upside down. That puts a lot of stretch on the ulnar nerve as it comes through the elbow and down into this 1.5 digits of the hand. Increased numbness, tingling, or sensitivity there tells us maybe we have some cubital tunnel syndrome. Don't forget to look upchain for any of those neuropathies, particularly if there's a median nerve, is it the pronator teres? If it's a radial nerve, is it the radial tunnel? Could there be some thoracic outlet syndrome involvement? And we as chiropractors should never forget the cervical spine, because 38% of hand and wrist complaints come from an asymptomatic cervical spine, according to a JMMT study. So we're going to look for motion palpation of the area and any orthopedic testing that could elicit that. You'll also want to know what questions to ask and when do we image these patients. Those answers can be found in the accompanying blog. And if you'd like to download a copy of this exam form, visit ChiroUp.com, go to the forms library and search for the hand and wrist exam. I hope this information has been useful. I'll look forward to connecting next time.